Thanks.
Good morning and welcome to Medical Grand Rounds. Before we get started today, just a couple of reminders and announcements. Next week, we will be hearing from Dr. Lenny Menken, who will be giving the talk Updates in Outpatient Medicine. And just a reminder, we are here on the Teams Live platform, bringing a broader viewership with a shared effort between Providence St. Vincent and Providence Portland Medical Centers. And Grand Rounds is currently only available virtually. That said, you can earn CME credit for watching live virtual or for watching the video, which is available at the same link as the invite for today's talk. I'll be monitoring the Q&A throughout the session today, and will mostly be holding questions to the end of the presentation as time permits. And now to introduce today's speaker, Dr. Joseph Bubolo. He is an oncology pharmacotherapy specialist with OHSU and an assistant professor of medicine with the Division of Hematology and Medical Oncology. He earned his PharmD from the University of Washington. And Dr. Bubolo maintains a clinical practice in oncology, as well as administrative responsibilities in patient safety and clinical pharmacy services, as well as research in supportive care for oncology patients. He is a sought-after teacher, and we are delighted to have him join us today. Thank you, Dr. Bubolo. I will turn it over to you.
Thank you for that kind introduction. Today's topic, as you see, is cannabis products, and is there a role for them in chronic pain management? Briefly, let's see here. The objectives today are to look at a brief history, and we're going to review the current knowledge of cannabis pharmacology, going to dip into the literature around the use for pain, and then really spend most of our time on the clinical impact, both positive and negative, that we'll see with cannabis therapies. Briefly, there is evidence that somewhere around 600 BCE in China that cannabis was already in use as a medicinal product. If we fast forward then to the 1800s, when it became widely utilized in the United States for a variety of medicinal purposes, followed by into the early 1900s, where Mexican Revolution led to immigration into the U.S., where a lot of cannabis came with that immigration. Around the time of the Depression, there was a lot of social unrest, and with resentment against immigrants who were competing for jobs, and public fear of cannabis as an intoxicant. This was followed by a variety of taxation acts and legislation which criminalized marijuana and its associated products. And finally, in 1970, it was made a Class 1, Schedule 1 controlled substance, which means it really had no medicinal use. Looking specifically at the United States, during the 1800s into the early 1900s, this was actually among the top 3 most prescribed agents in the U.S. There are things for labor pain, nausea, rheumatism, and with the criminalization, as I mentioned, it became Schedule 1 in 70, and then in 2018, we had our first non-synthetic cannabis product approved as an Epidiolex for several different pediatric seizure disorders. Cannabis itself is Cannabis sativa. It's a flowering herbal plant. There are both the indica and ruderalis species that are used medicinally as well. While originating in Asia, as you notice there, historically, it's a weed and it grows throughout the world pretty avidly. Currently, it's approved in 36 states plus the District of Columbia. It changes so often that I just have been sticking with greater than 30 on this slide. As of the last election, 14 states also allow a low delta-9 THC high cannabidiol product that for medical reasons that qualify differently actually in each state. The cannabinoid receptors, first one, the CB1, was identified in 1988. This is sprinkled throughout the central nervous system and peripheral nerves. And this is the receptor that is responsible for the classic marijuana-like effects on both psyche and circulation. The CB2 was identified in 1993. This is really something located around within B lymphocytes and natural killer cells, and has a possible role in immunity, poorly identified at this time. Most of the emphasis has been on the psyche or psychic effects of cannabis. We do have an endocannabinoid system, so we produce our own ligands for the CB1 and CB2 receptors, and this is anandamide and 2-arachidonylglycerol. These are endorphin-like effects that last just a few minutes, somewhere maybe as many as 15, depending on how you measure it. There are also endocannabinoids found in some other products, such as milk and chocolate. While we focus on the CB1 and CB2 receptors, there are many other receptor complexes that are impacted by the endocannabinoid system, which is highly integrated throughout the human body and used in both our development and as for a variety of other purposes. So while we focus on CB1 and CB2, the interaction of cannabinoids is so extensive that it is hard to separate it out from a lot of these other receptors that may be mediating effects that we're really not characterizing. When we look at the cannabis and how it comes from the plant, they all start out in the acid form, and through both time and heat, they are formed into the final product, so delta-9 THC or tetrahydrocannabinol, cannabidiol, cannabichromene. If it actually stays in the plant longer, so the people who are growing it are going to harvest at specific times to maximize the cannabinoid that they're after, you actually get other cannabinoids over time as well. The compounds that are primarily pulled from the cannabis plant, the marijuana plant, are terpenes, which are aromatic chemicals that are found in throughout all kinds of flora. And these are the things that give them their specific odor. And so the unique aroma and flavor of cannabis, which is very skunky actually, comes mostly from terpenes. Flavonoids are commonly found throughout a variety of plants, and they are known mostly for their anti-inflammatory and antioxidant properties. And while these are thought to be beneficial, it's unclear what they do as part of any medicinal effect that's coming from cannabis. Mostly the phytocannabinoids have been focused on. These are highly concentrated in the female flowers, and these are the ones that are going to bind to your CB1 receptor, CB2 receptors, and actually alter the neurotransmitter release from those receptor-associated areas in the body. So when we look at the most common cannabinoids in use, we have delta-9 tetrahydrocannabinol, commonly known as THC. This is the major psychoactive component, and originally it was somewhere between 0.5% and 5 or 6% through avid cultivation throughout the 60s, 70s, 80s of the last decade, the last century. We now have commonly cultivars that are over 20%. And actually, if you look at what's around Portland, most of them are over 30% if they're being used for recreational purposes. Cannabidiol it actually lacks psychoactive effects. It's thought to be possibly anxiolytic and through this mechanism possibly beneficial for PTSD. However, it has low to no affinity for CB1 and CB2 receptors, but it is known to modulate the action of and exposure of THC at these receptors. Overall, there's about 140 different cannabinoids, and overall somewhere between 300 and 400 different compounds when you look at flavonoids and terpenes as well. And the profile is going to be different based on each plant, each cultivar that it is extracted from. So kind of in summary, the light blue is your CB1 receptors, focused mainly in the central nervous system as well as in the peripheral nervous system. CB2s are in lymph nodes and other immune-related organs. And just the CBD, once again, doesn't really impact either one, but seems to modulate how other cannabinoids impact. So if we look at it, the pharmacology, oral THC, actually, I think I'm going to start with the inhaled. This is kind of the classic mechanism. And somewhere around a third of what is inhaled is absorbed. So when you're looking whether it be THC or CBD, if someone is smoking it, usually via a cigarette form, about a third of that is going to be absorbed. If you then compare that to the oral cannabis products, it's about a third less absorbed. And this is thought to be primarily due to the first pass effect going through the liver, as well as a certain amount of degradation from stomach acid. The fed state improves absorption for natural cannabis products, just as it is for the synthetics. So generally taking them with food, if you're going to take an oral, is recommended. CBD and THC are quite similar. The onset is in minutes, usually within 10 minutes for inhaled. However, due to the first pass effect and the different differential effects of the stomach acid and people's GI systems, you can have somewhere around 1 to 2 hours as the normal time to start feeling effects, with 2 to 4 being the peak, as opposed to 10 minutes with the inhaled. So the inhaled is a much more reliable, much more rapid form. However, you do have all the associated problems with smoking something. Duration, somewhere between 45 minutes and 3 hours for the inhaled. Generally, it's somewhere between 3 and 8 hours for the oral, so quite different. So the patient who is using something medicinally and expecting effect rapidly, especially if they're used to using an inhaled product and switch to an oral, can be quite disappointed that they're not getting whatever their normal effect is. Distribution is pretty widely bound to plasma proteins. There's about 10% that is going to be bound to red cells, and actually about 1% of the serum concentration gets to the brain. We do know that it does cross the placenta. It is found in breast milk. So pregnant or lactating females are going to give this to the baby. Oils and tinctures are absorbed, but we have actually no pharmacokinetic parameters at this time. It's a very lipophilic compound, and they generally cross over the skin, but nobody has actually done the pharmacokinetics on it. So when we look at the delivery and the nature of delivering cannabis, the smoking behaviors, large puff volume, big inhalation depth followed by breath holding, are what delivers when using an inhaled product. When vaporized, you actually get similar THC levels as smoking a cigarette, with a decrease in the burn compounds and the amount of carbon monoxide that the inhaler is going to get in. Pipes generally give a higher THC level than cigarette forms due to lower smoke loss. Sublingual and oral are going to be very similar in their absorption, and once again, they have those variable onset times. And then, as I mentioned, you really get quite a bit more if you take it with food. For this maximal concentration of CBD, for example, increases about 5-fold, and the AUC around 4-fold with a high-fat meal as opposed to the fasted state. The average individual needs 2 to 3 milligrams of THC to result in a high or intoxication effect. The oral dose is going to be somewhere between 3 and 5 times that amount. And that's once again due to the degradation and first pass metabolism. The Oregon recreational products are aimed at 5 milligrams per dose. So if you think about 5 milligrams, oral is about 1.5 to 2 inhaled. And that's kind of where that derived from. However, you look at other states, and if somebody is buying something out of state, you can, using Colorado as an example, you can find quite different doses available. If you're trying to actually calculate the dose the patient is taking, if you look at the packaging of the edibles, the packaging is going to read similar to a food product, in that it'll have like the most to the least common ingredient, and then they will actually have percents or milligrams, and then you would just look at how much they used and calculate that out. Same for the smoked product, you'll find a percent of THC usually, and then sometimes some of them will have a complete profile of the terpenes and other products on there as well. It varies by distributor. There are really extensively metabolized in the liver. Delta-9 THC is primarily via CYP2C profile. The THC in liver is actually metabolized to 11-hydroxy-THC, which is 4 to 5 times more potent psychoactively than the parent form. And so if you think about it, if you have a first pass through the liver, ingested is actually going to give higher rates of intoxication, though delayed onset. And this has actually been a problem with some individuals where they stacked, so to speak. They took a dose, they didn't feel the effect. They took another dose too rapidly, and ended up having quite hallucinatory events. There's actually been at least one death associated with this, where someone hallucinated and stepped off a balcony. CBD however, is primarily CYP3A4 and 2C19 metabolized, with some in also the UGT enzymes. Much longer half-life, somewhere between 56 and 61 hours, as opposed to the 3 to 8 that we saw with THC in the earlier table. And if you have liver compromise, these are going to have delayed clearance. This is really a fecal excretion much greater than urine. And so if somebody actually has renal failure, including being on dialysis, their dose is going to be the same as someone with normal kidney function. This is a table that's been put together over the last several years, and the bottom, and I have to say many of the sources are nuanced, and so we kind of do our best as we can to put it together. But if you look at the different compounds, whether it be THC, CBD, CBN, dronabinol, nabilone, there's variability in each of these as far as which CYP system they are going to impact. And you really have to take it one by one, and it's somewhat of a guess with the natural marijuana products, as I'm going to point out with the products here coming up. Dynamic interactions, though, THC actually diminishes the effect of CBD. CBD tends to decrease THC psychoactive effects, but we're also seeing some contradictory data there, and it could be due to the formulation of some of the quote-unquote CBD products having additional cannabinoids in them, not being pure CBD. It's still kind of being worked out. If there is another sedating agent on board, whether that be a hypnotic or an antihistamine or an anti-anxiety agent, these will generally augment that effect. Whereas if somebody's on a stimulant, say for ADHD, for example, is going to oppose that effect. The psychiatric drugs and lithium have variable effects, and they're not always predictable. If we look at the prescription cannabis products, we have dronabinol, which is a synthetic delta-9 THC in sesame oil. It activates both the CB1 and CB2 receptor with similar affinity, but efficacy is going to be less at the CB2. We don't actually know what it does to the immune system. Nabilone, which is rarely used in the US, is also a THC mimic. It's another synthetic product that hits both receptors. And then we have cannabidiol, in the form of Epidiolex, which is a purified cannabidiol from plants, a single cultivar. It's been standardized to 100 milligram per mil, and comes as an oral solution. I think it's like strawberry flavored, and once again, it really doesn't impact the CBD receptors, CB receptors. So when we look at cannabidiol, this is by definition in the US, hemp derived, with a maximum of 0.3% THC. If you look out there at the marijuana-derived cannabidiol, you'll find quite variable THC. If you look at Epidiolex, this is actually a low THC cultivar, which is generally less than 0.1%, not standardized for terpenes or flavonoids. All of these are coming from different cultivars of cannabis sativa, and can be variable in other content other than THC, and the CBD is going to be characterized in milligrams. So if we look at common cannabis preps, there's marijuana, which while it is available in leaves and stems, they're mostly selling flowers, also called bud. Hashish is going to be a resin, sometimes coming as a cake. Not so widely used as it was before it was being legalized for recreational use. Tincture is a different, we're used to hearing the word tincture pharmaceutically and having an alcohol diluent when we get tincture of paregoric or something like that. However, any liquid infused with cannabinoid, whether that be soda pop or some other flavored drink, is considered a tincture. So there actually shouldn't be alcohol if it has THC in it. Oil have been extracted from the plant with many different solvents. CO2 is becoming the industry solvent of choice. It's not explosive as butane, ethanol, and propane are, so there's less likely to be an industrial accident. And also it doesn't leave organic residues. So you'll find that CO2 extracted oils are the ones that are most commonly seen out there. Infusions are cannabis plant material that's been mixed with a non-volatile solvent. So this is the butter, cooking oil, and other things that are used to make cannabis edibles. And these edibles come in a wide variety of choices, from cookies or brownies or something like that. There's sodas and other gummies, and pretty much anything you can think of has been cooked into it, into a cannabis edible. The hemp products are once again primarily providing CBD, and they'll have variable THC content depending on where they're grown. Since these are natural products, there is a lot of question around purity and content. So herbicides and pesticides, while Oregon tests for these, it's I don't know that every lot, and actually Washington has a similar policy, is tested. Potency is THC and other cannabinoid content are tested for as the grower or manufacturer is looking for, but it's mostly just THC and CBD that are shown. About half of these products or more are going to be mislabeled, and once again, I have some things coming up for that. When we get down to it, if we're going to use it as a medicinal, the medical dose for any condition currently is unknown, and we'll talk a little bit about what's been done to look at that. This is one of two JAMA papers I have for you. This was cannabis edibles. 75 products these were bought from dispensaries, and they looked at THC and CBD content per assay, and about 1 in 5, 17%, were accurately labeled. About a quarter were underlabeled, meaning they had more in it than were on the label, and about 60% were overlabeled, meaning they had less in it than was on the label. If you look at the THC to CBD ratio, they much as 36 to 1, 36 THC to 1 CBD, and it went down to one product which had a 1-to-1 ratio, which is similar to some that are used medicinally. It is important that all of these have child-resistant packaging. If we look just at cannabidiol, which had grown rapidly in popularity as it became available in many states, whether it was oil, tincture, or a vaporization liquid, those accurately labeled varied pretty widely. And once again, there's a tendency towards over-labeling or under-labeling. So these were all bought over a 1-month period. They sent to an independent lab, and they were bought from the internet. So it's recommended that if a patient is going to purchase, that they actually stick with a local dispensary, which is probably going to have a more reliable supply, especially if they stay with a single brand. It is notable that though cannabidiol is supposed to have less than 0.3% THC, some of them had really pretty significant amounts of THC in the CBD, though it wasn't labeled as such. So the medical use of cannabis, it is really aimed around what the cannabinoid system does. And there's mainly 4 groups of psychological effects. You see affective, so euphoria or easy laughter. So these are the typical cannabis highs that are sought. Sensory, so you'll see some temporal and spatial perception alteration, some disorientation. This is pretty common. You do see drowsiness, dizziness, and a change in motor coordination. And then nobody's going to think more clearly on on cannabis. So confusion, short-term memory lapses especially, and then changes in concentration are common. When we think about the potential uses, the things that have been aimed at and appear to be best supported by anecdote that is out there and the limited studies are pain management, benefit for nausea, appetite boosting, so for anorexia, cachexia, and their seizures with the new Epidiolex in the pediatric seizure disorders, and then muscle spasms. While these other uses are out there and they vary state by state, they really aren't well supported at this time, and it's clearly under clinical trial. Going to focus on analgesia and the use around them with cannabinoids. And this statement here from the National Academy of Sciences, Engineering and Medicine, 2017. Sorry. This was a consensus, 4-1, voted that it was beneficial in chronic pain. They were more in agreement on antiemetics and multiple sclerosis symptoms. So they felt that basically there was moderate evidence for cannabinoids in a variety of different disorders. If we then look at a meta-analysis, this is a 2015 meta-analysis, and there were a bunch of them that kind of came out in that time. There were around 6,500 citations in Medline at that point, and they came up with 28 different pain studies. If you look at this, some were for nausea, some were chronic pain, spasticity, various other things. The ones that we're interested in used nabiximols, nabilone, smoked THC, and a variety of other products. There were half of these about half of them are parallel, about half of them crossed over. And if you look at the odds ratio here, there are some that indicate that there was benefit seen in improvement of cannabinoid over placebo. And there's one here that looked at about 0.9 gram cigarettes 3 times a day as their dose. And they saw reductions in pain and maybe by a third compared to about 1 in 5 or 6 when you look at by placebo. This is a meta-analysis, and it was confounded. I mean, if you look at it, there are a lot of different products that were used. The evidence is, if anything, moderate quality, and the thought is that neuropathic pain or maybe cancer pain was going to benefit. However, these are all short study length. They used a variety of outcome measures. They were not blinded. Oops, things are moving on me again. They're not blinded, and crossover trials were actually not included in the analysis, just the parallel designs. If we fast forward to last year, there were actually 3 or 4 different meta-analyses came out last year. If you look at Medline, there's around 13,000 articles, so it's almost doubled since 2015. Under a little more stringent criteria, there were 54 of those 13,000 that were eligible for review, and 39 met full criteria. And on pain, you looked at neuropathic, nociceptive, and cancer pain. All of these, once again, are confounded by small sample sizes, short duration of follow-up, high attrition rates, and patients had to have stable pain scores, so maybe not the worst patients with the worst types of pain, and actually to be reviewed on these studies. So bottom line is there aren't valid studies out there that I could present to you today. I couldn't actually select one because there's nothing that actually compares different types of medical cannabis head to head, and there's nothing with long-term pain control with the medical cannabis. If you look deeply into that and kind of parse it out, the number needed to treat for benefit when you look across these many trials is somewhere between 3 and 20. The benefits that are seen are more likely in chronic non-cancer pain. They seem to benefit those with fibromyalgia, non-chemotherapy-induced neuropathic pain, cancer-related pain, and then rheumatoid disease. And if you think, once again, back to the 1800s, rheumatic diseases was one of the uses. Oddly, though, even though we see signal in neuropathic pain, diabetic neuropathy has really inconsistent results. So while it's not chemo-neuropathy and it's not diabetic, other types of neuropathic pain seem to benefit in some way. Other benefits that have been seen is an improvement in sleep quality, and this is something that anecdotally many individuals use it for. When you look at the assessment of pain control on the scales, most of them have a 1 to 1.5 point decrease when you see those that look to have benefit. And some people, so about 1 in 4, will have a greater decrease in their pain score. And when you look at the products that are inducing these results, it's really the pharmaceuticals, nabiximols, which is a 1-to-1 CBD to THC ratio, and then dronabinol, which is the synthetic THC product that's available in the US. Nabiximols is available in about 8 different countries currently, and is phase 3 trials in the US for multiple sclerosis spasticity. The other thing that prior to the pandemic was a lot in the news was, should opioids be replaced with cannabis for pain? And there was these state level epidemiologic reports that were suggesting lower overdose deaths in states that legalize cannabis. And these are, once again, big reports. When you actually drill down, and we had been kind of waiting for those to see, there was one prospective 4-year cohort study with around 1,500 individuals, chronic non-cancer pain, and they were looking at concomitant cannabis use with opioids. And what came out is those that used cannabis had more subsequent pain, less self-efficacy in managing their pain, and actually did not decrease their prescribed opioid use. So the bottom line is, even though there's this epidemiologic stuff, when you look at the individuals, they don't really appear to be helped. And so we're not, and I don't think anybody is actually supporting, in a evidence-based way, the replacement of opioids with cannabis at this point in time. Canada has moved forward with a adoption of medical cannabis, and actually is currently putting out the best guidelines that are out there. And I'm throwing these out because the anecdote is so strong that no matter what the evidence says, you're going to have patients that are using cannabis products. So their guidance is you start low and you go slow, because there's a U-shaped curve. Initially, as they start at low doses, they see benefit, and depending on what they're using it for, whether that be sleep or pain or nausea or appetite, as they increase their dose, you get into the bottom of the U, and they have a kind of an ongoing benefit usually. If you keep increasing the dose after that, then you see a sharp uptick in side effects, adverse side effects. So generally, their goal is a starting dose of around 2.5 milligrams. This is all oral of THC content, and everything is based on THC. They are not looking at the mixtures of THC, CBD, and other cannabinoids. 5 milligram is considered a moderate dose. 10 is strong. Anything that is 15 or higher sees an increased risk for adverse effects. And for the treatment of pain, they suggest 25 be the ceiling dose. That you don't, if you're going up any higher for pain management, that all you're going to really get is adverse effects without additional analgesia. I tried to find a threshold dose for CBD, and there actually isn't one. The dose with the Epidiolex for seizures is well documented, which is somewhere between 5 and 20 milligram per kilo. But for any other use, there is currently not a recommended dose, and you'll see pretty widespread dosing for the things that are used out there. With that, I was going to look into, so if we're going to use it and people are using it, what do we see as far as effects, adverse effects? When we look at a hard drug versus a soft drug, a hard drug being things like heroin, this is a soft drug. It's less addictive, it's less dangerous, because it's almost impossible to overdose and die from too much cannabis on board. If you hallucinate or something, it result in a death, but it's not directly related to loss of breathing like with heroin. The overdose risk for marijuana is you'd have to literally eat about a bale of it, which would be pretty tough. When we look at cannabis side effects, the really common things that happen, increases in anxiety, confusion, cough. This is really with smoked cannabis. Dizziness, drowsiness common, as are fatigue, and actually nausea, depending on how they're taking it. Blurred vision and headache, certainly intoxication is the goal for many. And then rare things you see are some balance problems, changes in rhythm, hyperemesis, low blood pressure, psychoses. And if you then quantitate these and put them side by side with the commercial products, dronabinol, nabilone, and cannabidiol in the form of Epidiolex, and compare them to cannabis, smoked marijuana, or something similar, you see that there's a pretty different effects as we start to parse out something that is a specific cannabinoid versus these mixes. And if you look at cannabidiol at high doses as used in Epidiolex, it's actually an appetite inhibitant as opposed to a stimulant. It has pretty high levels of diarrhea, which you don't see with the THC mimics. So, but it has really no dizziness, which you see quite commonly with whether it be marijuana or either of the THC mimics. So I thought it was really interesting to put these kind of in a table as we would compare pharmaceuticals to see how they add up. And I think as more and more of the different cannabinoids are pulled out and focused on as medicinals or whatever they're going to be used for, this would be an interesting way to compare them. So who should not be using cannabis? If we think about that, anybody with a psychiatric history, we know that those with schizophrenia tend to express more commonly and at an earlier age. Those that are pregnant or breastfeeding are going to be transmitting it to the infant. And we know that endocannabinoids are widely prevalent in the development of children. And along with that is the should 21 actually be the age of use, because the brain continues to develop somewhere around 25. So I'm sure that's never going to change. It's certainly something to think about as we see younger people using it, and there's also more cannabis use disorders in younger individuals. And then those with significant cardiac history should not be smoking this. It's only with the smoked that you see the changes in blood pressure, the changes in heart rhythms that have result in MIs in usually older individuals over the age of 60. Speaking of use disorders, there is dependence that has been seen. While it's considered non-addictive, especially when ingested, it's with regular use, dependence develops in somewhere between 9 and 10%. This is more common in the young user than the older user. If you compare that to nicotine, which is about 32%, heroin, which is about 1 in 5, cocaine, or alcohol, which are alcohol more, cocaine similar. There is a physiologic withdrawal after long-term use. And as far as what an abstinence syndrome looks like, generally mild. It's only if they're regular users. But irritability, insomnia is probably the most common thing amongst them, where they have sleep disturbances and really are not able to sleep regularly or in a deep fashion. Restlessness, hot flashes, nausea, and cramping. It's stored in adipose tissue, so it's excreted at a pretty low rate. If someone's actually doing urine testing for a job or something on that order, if they are a regular user, it'll be there for weeks, probably easily out to 4 to 6 weeks. So while we have this 1 to 3 day half-life, it can stay in the adipose tissue for a much longer period. Driving and the accidents around it are pretty consistent that it about doubles the rate of auto accidents. And this is not someone who is clearly drunk, as you would see with somebody who's ingesting alcohol. They will really not feel impaired or anything. And what happens is they tend to overestimate their impairment. They're driving carefully, but they forget all the automatic functions of driving. So they're less likely to use a turn signal. They're less likely to hit the brake pedal when they see a flash of brake lights in front of them. The things that are normally instinctive in the experienced driver, seem to fall off with the use of cannabis. And this is whatever the country you're in, this is being seen. So there's a French study. If you look at April 20th versus a week before or after, April 20th is a kind of a cultural cannabis day in the United States. You see a much higher 12% increase in fatal car crashes on that versus a week before or after. If you are driving in Colorado now and you rear end somebody, they automatically check to see if you have cannabis in your system. And once again, it's a recognition of the loss of that automatic safety things that you do when you drive. Hyperemesis syndrome is something that was really either under-recognized or just not reported prior to around 2004. Cyclic vomiting syndrome is often confused with it because a lot of those with cyclic vomiting syndrome use cannabis in an attempt to control it. We don't know actually what's causing this hyperemesis syndrome, whether it's high THC plants or something else that is coming along with it, or maybe even in pesticide or other impurities. But if you look at who, it's generally median age is around 25, though a pretty broad range. Almost all of these are going to be daily cannabis users, and somewhere around 10 years from the start of use is when you see the onset occur. It's 4 to 8 week cycles, and there's a characteristic prodrome, there's the hyperemetic phase, and then there's a recovery phase. And this is thought to be possibly mediated by enteric CB1 receptors. What's pathognomonic here is that the relief is rapid and transient with a hot bath or a hot shower. And it appears to be temperature dependent, the hotter the better, to the point where individuals will take 2 dozen showers or stay in a hot tub all day. There's even a case or two of people who scalded themselves in an attempt to resolve this syndrome. Resolution actually varies from hours to weeks. A lot of drugs have been tried in ED departments or the occasional inpatient who's hospitalized for this. Haloperidol, capsaicin, aprepitant may be beneficial, but they're all case report level of evidence at this point in time. The only proven treatment is actually abstinence, and once they stop using, you generally will see them get better. If someone is in and they're not getting better, so the first thing we look for is whether somebody continues to bring them in cannabis products, and this has almost always been why they don't improve. So if we look at the take-home points here, from a risk standpoint, it's unclear, and I didn't really focus on this, but whether lung cancer and vaping are thought to, if you're smoking a cannabis cigarette or pipe, that probably has similar risk for lung cancer as tobacco does. When vaping, you're thought to have a lower cancer risk due to less inhaled burnt products and other things that come with it. There is a cardiac risk in the elderly individual or those with pre-existing cardiac disease, and that's really with inhaled cannabis, and they should stay away from that. If they have a psychiatric disorder, there's certainly no clear benefit in any of them. There's harm likely in both schizophrenia and bipolar disease with loss of control, even if they are continuing to use their medication. There is a dose-dependent relationship between exposure and psychosis and schizophrenia, with adolescents and young exposures seeing this more commonly. And really less than 25, you could say it shouldn't be used, as it is part of normal brain development. The endocannabinoid system is. While they're less habit forming than nicotine and certainly the hard drugs that are out there, the risk is real. Somewhere around 9% will have a cannabis use disorder, and this is more common in adolescents. We still don't know what pregnancy or exposure in utero does. In those that have been born to someone who's a regular cannabis user, there tends to be some delay in ocular development. The children don't seem to see normally, but that seems to normalize over the first weeks of life. And if you follow these children into their teen ages, they tend to have lower levels of achievement and maybe when we think about academics, but there's no really randomized or controlled data that says that isn't just normal teen behavior. So that is still unknown, but the recommendation currently is to avoid during pregnancy or when breastfeeding. We really need more studies in the higher risk subgroups, older adults with chronic diseases that can tell us whether there's benefit or we're going to see more harm than benefit. The problem is it's really hard to find factual information, no matter what you're looking for, and the products that are out there are unregulated in any meaningful way. What they get at a dispensary is what that producer decided to make at that point in time. And while there are some really good, even pharma grade producers out there, it's quite mixed what will be in any particular dispensary. So the true medical benefits are unclear. I think there are some clear areas of promise. With pain relief, especially neuropathic pain, this should be an active area of research. Muscle disorders, I think we're going to see nabiximols approved probably in the next 1 to 2 years for multiple sclerosis spasticity. We already have the Epidiolex for seizure disorders. Appetite and nausea, dronabinol has been widely used for this. Also, the use of cannabis for those with appetite problems. It's and actually HIV cachexia is an approved use of dronabinol. So this is, I think, going to continue to be an area of use. The one thing that you see when you talk, I've talked to actually many patient groups, and the mood is the most common benefit that they see. They may not say that they have less symptoms. They may not say that they have a better.
Dr. Bubolo, I think we just lost your audio.
I'm not positive, but I think if anybody has his phone number, I think that we can invite him and then he can just answer the phone and talk us through the rest, through the Q&A.
Great. Thank you to our audience for bearing with us here a moment. I think
I have his number. I thought it was my computer.
Yeah, if you want to type it into the chat, then I'll invite him.
Let me see if I have it. I gotta look it up on my email here really quick.
Thank you to the audience for bearing with us as we work on getting Dr. Bubolo back on audio. You may be able to reach him by phone to answer our questions. And I do see some questions that have started to come in. One comment as to whether the age restriction for legal use to be increased to 25, given what we know about brain development. And I think we could see that somewhat addressed in Dr. Bubolo's presentation with regard to unlikely to see a change in the legal age, but certainly concurs with the notion of some risk for use at age 25 or less.
I'm sorry, I have so many emails from him. I don't have his number. I gave him mine. Let me see.
He's actually in the chat now, and he just,
Okay.
so he's going to give us his phone number, I think, in just a sec.
Okay.
Great. I will go ahead and call Dr. Bubolo, and we will do that by telephone.
I am inviting him into the meet from phone.
Pardon?
Hello?
Oh.
Hello?
Great, that's working. We can hear you again.
When did you lose me? I'm so sorry.
Just right before your slide that asked if anybody had any questions. So we only didn't hear you for the very last slide.
Oh, awesome. At least the talk came through. Is there a question I can answer via phone?
Great. Thanks, Dr. Bubolo, for bearing with us. Do you hear me?
Yeah, I can hear you just fine.
Great. So we already addressed a question related to age of use, and I think you acknowledged in your talk that certainly some risk for those particularly under age 25, but that we may be unlikely to see a change in the legal age.
I'm sorry, go ahead.
There were a couple of questions, particularly curious about topical use. Earlier in your talk, you acknowledged that there's pretty limited data here, but any comments that you've had either with dosing or efficacy or safety concerns specifically for use of topicals?
Yeah, currently there are no safety concerns. We know that it's absorbed. It does not. There does not be enough absorbed to cause an intoxication or change in coordination or anything like that. The efficacy is unclear because if you look at the products that are out there, while many of them have CBD or a cannabis mix in them, there's also products that are starting to add methyl salicylate, things like Bengay, and other compounds in there. So I think we just don't know actually what the true benefit of a topical is. And there isn't a good placebo-controlled study that I can reference at this point either. Pharmacokinetically, we're still waiting on that data.
Thank you for your thoughts there. A quick question here with regard to whether there's a known tachyphylactic effect associated with cannabis product use.
There's a clear tolerance to the side effects, and it's thought to be almost as much experience as anything else, where someone gets used to the intoxication level, and but those that are regular users, that are recreational users, do tend to notice that they have to go up over time a little bit in their dose to achieve the same level of intoxication, or high as it's known.
Thank you. We have a comment here from someone online that I was not aware of, saying there's evidence that marijuana use in hepatitis C is associated with increased fibrosis. Not sure if you have any additional comments there. And I believe you already in your talk addressed the second part of the question, which was, are there other situations where marijuana use may be detrimental? And you did speak to some specific populations there in your talk, of course.
Yeah, the liver fibrosis would be a really confounded thing. There's so many impurities in cannabis products at this point in time that it would be hard to tell whether they got into a bad batch, so to speak, that even earlier extraction techniques where you had all those organic residues left over would be suspect. So it would be, you would have to really dive into what they were using and how they were using it. And I know Hep C users, similar to some HIV users, were using it for appetite stimulation and benefit. And so it would be hard to determine whether it was cannabis or something else that actually caused that increased fibrosis.
Great, thank you for that. And then certainly we have seen, regardless of what is available for official guidance, certainly we have patients coming to us with questions or who are using themselves. From a practical standpoint, any advice either for clinicians or for sharing with patients with regard to good sources of information or any guidance on dosing and formulations?
Yeah, the dosing and formulation, we don't recommend any inhaled form. I think all of those come with a lung cancer disease, pulmonary disease, and lung cancer risk, which I can't see, given the unclear benefits, that it can ever be recommended that way. So we suggest only using the oral edibles. That dosing slide with the start low and go slow is where we go with that. The goal being that they have to recognize that you don't take a second dose for 2 to 3 hours after starting it, and that you're going to have to have a regular place that you purchase it. We recommend a dispensary over the internet, and that they should try to get the same brand. They have to recognize that they're doing kind of an N of 1 trial on themselves, and that they will. They have to recognize that if they have adverse events, they're going to be going back to the bud tender, who is their advisor at any dispensary, and seeing if they can get something that has a lower potential for those side effects. Some in the cannabis industry have actually started putting colors on them, so there'll be like a blue color, red color, purple color, and the colors, the hotter the color, the more likely there is to be intoxication. The more subtle the color, like blues and purples, they're less likely to be intoxicated and more likely to achieve other benefits. So there isn't standard advice other than don't use inhaled, and consider the dose that you're getting. And we never say, actually 10 milligrams of THC is probably as high as we would recommend going. The other kind of milieu that's there, the terpenes, the flavonoids, are still yet to be characterized, but some very experienced users will seek out certain levels of those as well. Bottom line to the questioner is the start low, go slow, oral only, and they have to be aware that they shouldn't drive, and keep away from children and pets.
Great, thank you. That's extremely helpful. And you did note that in your comments now and in the Canadian guidelines, the specific dosing is for the THC component and does not exist in the same way for the CBD component. Can you remind us of any rule of thumb there with regard to dosing of what might be a start low and go slow for the CBD component?
So CBD has mostly been dosed per kilo. So in the adult, I would think a 25 to 50 milligram dose would be a reasonable starting area. The concern there is how pure of a CBD product it is, because a lot of them will be adulterated with THC, and if they have a significant amount of THC, they're at risk for an adverse high or intoxication event. So I would actually go pretty low, probably 25 milligrams or less for the initial dose. Try to stay with the same lot and product, and also the advice we've given for many years with natural products is they have to have a goal on what they want to achieve from the therapy. So if it's pain relief, do they have some kind of measure that they will look at and say, if my pain is not better, I'm going to quit using this. Or if I'm not able to, walk the dog or do household chores or whatever it is that is my goal, that this is helping me do, really to think about that and be as objective as they can, whether they achieve their goal or not.
Great, thank you. An extremely helpful comment to end in, applicable to cannabis and so many other treatments, what goal do we have in mind? We are just coming up on the top of the hour at 9 o'clock. Thanks for everybody's patience, yours in particular, Dr. Bubolo, with bearing with the technology and answering questions by phone. We will see you next week. Have a great day.
Thank you. Appreciate your help.
Thank you, Dr. Bubolo. Have a good day, everybody.